Honorable Chairperson Sir, respected teachers and learned audience. Assalamu alaikum and good morning everyone. I am Dr. Farhan Tamit Naim, Indoor Medical Officer, Department of Surgery. Welcome you all on today's clinical seminar on 7 years old female child with severe upper abdominal pain. Today's seminar will be chaired by Professor Dr. A.S.M. Lokman Hussain Chaudhary Sir, Professor and Head of Department of Pediatric Surgery. And today's seminar will be presented by Dr. Mehdi Hassan Iqbal, Indoor Medical Officer, Department of Surgery, Pediatric Surgery. Now, without any further delay, I would humble request to our chairperson, sir, to come to the dais and conduct the rest of the session. Thank you all.
Assalamu alaikum. Very good morning. Today's seminar is very important for all of the doctors. 7 years old girl with upper abdominal pain, severe upper abdominal pain. Our today's speaker, Dr. Muhammad Mehdi Hassan Iqbal. Iqbal obtained MBBS degree from Silet M.S.D. Osmani Medical College, 2016. Recently, he obtained a MRCS degree from Ireland. Now, I am requesting Dr. Mehdi Hassan Iqbal to present his clinical seminar.
Thank you, sir. Thank you for such a nice introduction. Let's start our today's seminar. Today's topic is a 7-year-old female child with severe upper abdominal pain. So, particulars of the patient. Patient named Labiba, 7 years old female. She is Muslim from Horiampur, Trishal, and she was admitted on 30th June on this year, and she was examined on this year, on the same date. She presented with upper abdominal pain for 10 days and vomiting for single episode 1 day ago. According to the statement of the patient, she was reasonably well 10 days back. Then she developed upper abdominal pain, which was mainly in right upper quadrant, which was sudden onset, and the pain was first in bearable limit, then it became very severe for last 1 day. It was colicky in nature, radiating to back, increase in severity after taking meal, and there was no known decreasing factor. There was no specific time duration and interval for this attack. The pain was associated with vomiting for 1 episode 1 day ago, which was moderate in amount, non-bilious, non-projectile, and there was no foul smelling, contained undigested food material, and bitter in taste. Her attendants also complained of a failure of growth according to her age. She had a normal bowel and bladder habit with normal color of stool and urine. No history of having any abdominal mass, jaundice or itching. There was no history of having intolerance towards fatty food. Also, there was no history of pain in the shoulder tip. Patient had no history of fever, weight loss, hematemesis, melena or hematochezia. She had no history of trauma to abdomen and no history of contact with any tuberculosis patient. With the above mentioned complaints, she was admitted to the pediatric surgery department for better treatment. She had a history of appendectomy 8 months back in another private hospital, of which she failed to show any documents regarding operation. She is first issue of her non-consanguineous parents, and none of her family members are suffering from this type of disease. All members are leading a healthy life. She was delivered with normal vaginal delivery at term at hospital. Her antenatal and postnatal periods are uneventful. Feeding, she was on exclusive breastfeeding up to 5 months of age and then started on weaning slowly. Currently, she is on family diet. Her development was proportionate to age. She had no significant drug history for this condition. She is completely immunized as per EPI schedule, and she belongs to a lower middle class family. Her family lives in a tin shed house with a sanitary toilet, and they drinks tube water. She had no known allergic history to any food or any medications. So physical examination, on at first general examination, her appearance was ill looking. She was cooperative and decubitus was on choice. Anemia, jaundice, cyanosis, clubbing, koilonychia, leukonychia, dehydration, edema, all were absent. Her blood pressure was 90 by 60 millimeter mercury, pulse 90 beat per minute, respiratory rate was 20 breaths per minute, and there was no accessible lymph nodes. There was no palpable accessible lymph nodes, and her hernial orifices were intact. Skin condition. She had a normal skin condition with a normal hair distribution, and the BCG mark was present. Her anthropometric measurement shows weight was 14 kg, height 108 centimeter. Weight for height shows minus 3.2, which denotes severely wasted, and height for age denotes she was severely stunted, and BMI was 12, which is below 5th centile, denotes severely underweight. On systemic examination, at first the abdominal examination, inspection, there was the shape of the abdomen was scaphoid, which was the umbilicus was centrally placed and inverted. There was no visible swelling or lump. Pigmentation, visible peristalsis and angorge veins are absent. There was a scar mark in her right lower abdomen, lens incision mark actually, and external genitalia was normal. On superficial palpation, temperature was not raised, and tenderness present in right hypochondriac and epigastric region. And on her deep palpation, there was tenderness and muscle guard or rigidity present in right hypochondriac and epigastric region, and there was no palpable lump. And on orgal palpation, there was no organomegaly. Murphy's sign was absent. And percussion, we could not perform percussion because of her severe tenderness. And on auscultation, bowel sound was present, bruit, there was no audible bruit. On digital rectal examination, there were no perianal swellings, intake, fissure or any other abnormality, and on palpation, anal grip was normal, rectum was empty. Other systemic examinations revealed normal findings. So, our patient Labiba, 7-year-old girl hailing from Horirampur Tishal, admitted in this hospital with the complaints of severe pain in right upper abdomen for 10 days, which was sudden onset, colic in nature, radiating towards back. Pain was initially tolerable limit, but then suddenly became very severe for last 1 day. The pain usually increased after taking meal, but there was no specific decreasing factor. The pain was associated with vomiting for 1 episode, which was moderate in amount, non-bilious, non-projectile. There was no foul smelling and contained undigested food material and bitter in taste. She had a normal bowel and bladder habit with normal stool and urine color. No history of having any abdominal mass, jaundice or itching. There was no history of fatty food intolerance or any shoulder tip pain or any history of trauma to her abdomen. Patient had no history of fever, weight loss, hematemesis, melena or hematochezia. There was no history of contact with any tuberculosis patient. According to her informant, she was failing to grow according to her age. She had no significant past history except history of having appendicectomy 8 months back in a private hospital, but failed to show any documents regarding operation. On general examination, everything revealed normal except her anthropometric measurement shows severely wasted, stunted, and her BMI indicates severely underweight. On abdominal examination, there was a transverse scar mark present in her right lower abdomen. Her abdomen was highly tender with presence of muscle guard in right hypochondriac and epigastric region. There was no palpable mass in right hypochondriac region. Murphy's sign was absent. There was no organomegaly, and bowel sound was present, and there was genitalia was normal. On digital rectal examination, findings were within normal limit. Other examinations also revealed normal findings. So, what could be the possible diagnosis?
Dear audience, what might be the diagnosis? Provisional diagnosis. Common bile duct obstruction. Liver point.
Liver point subject to undigested food after bitter in taste. তার মানে হচ্ছে স্যার যে বাইটা পাস হইতেছে না।
Also the non-bilious. Vomiting non-bilious. ঠিক আছে না হতে পারে না তা না টোটালাইজ করে না হতে পারে তো তখন লিভার পয়েন্ট বলতে হবে যে এই পয়েন্টের ভিত্তিতে স্যার আমি বলতেছি এটা কোন বাইল ডাক্ট অবস্ট্রাকশন
cholecystitis, choledolithiasis,
cholecystitis হতে পারে cholecystitis হতে পারে টিপিক্যাল যে ফিচার থাকে সেটা অবশ্য না হতে পারে নেক্সট আর কোন ডায়াগনোসিস আমি জুনিয়রদের অ্যাসিউর করছি যে ভয় পাওয়ার কিছু না 7 কোন মাস আপনারা বলতে পারেন যে ডায়াগনোসিস এটা হতে পারে লিভার পয়েন্ট বলতে পারলে ভালো না বলতে পারলে কোনো অসুবিধা নেই একটা দিয়ে তো বলতে পারে না আপার রাইট আপার অ্যাবডোমিনাল পেইন কি হতে পারে পোস্ট অপারেটিভ ব্যান্ড অ্যাডিশন হতে পারে যেহেতু তার অপারেশনের হিস্ট্রি আছে 8 মাস আগে ঠিক আছে তবে সেই ক্ষেত্রে যদিও এখানে ওরা বলছে পেশেন্ট বলছে কোনো ডকুমেন্ট নাই ওরা বলছে অ্যাকিউট অ্যাপেন্ডিসাইটিস যদি এটা ফার্স্ট অ্যাপেন্ডিক্স হয়ে থাকে সেই ক্ষেত্রে ব্যান্ড অ্যাডিশন হওয়ার সম্ভাবনা বেশি হতে পারে থ্যাংক ইউ আর কিছু আর কোনো কিছু বলতে কেউ acute intestinal obstruction হতে পারে সাবঅ্যাকিউট কেন বলতেছ সাবঅ্যাকিউট কেন বললে সেটা আমি একটু তুমি জানো কিনা
Pain, abdominal pain,
ভেরি গুড
vomiting,
ভমিটিং আছে
single episode.
bowel habit normal but oral habit normal ঠিক আছে এই ক্ষেত্রে সাবঅ্যাকিউট বলা যাবে জুনিয়রদের মধ্যে যে কেউই বলতেছে না অ্যাকিউট অ্যাবডোমেন তো হতে পারে অ্যাকিউট অ্যাবডোমেন হতে পারে এটা কেউই বলতেছে না কিছু না পারলে বড় একটা টার্মে আমরা অ্যাবডোমেনের কন্ডিশন দিয়ে একটু আর কিছু তাহলে আমরা প্রসিড করি
So, based on this history, our provisional diagnosis was acute pancreatitis. And our differential diagnosis were acute cholecystitis or worm in the common bile duct.
Points
Acute pancreatitis patient had severe pain in the epigastric and right hypochondriac region, and the pain radiates towards back.
Thank you, Speaker, for a nice presentation. Sir, I have a query for examination findings and from history. You have mentioned there is a history of failure to thrive, that is growth failure, and severely stunted and severely wasted. But you have mentioned anemia absent. How could it possible, sir? If there is growth retardation and severely wasted and stunted, definitely anemia is there, sir. But anemia is absent totally. How, sir? Speaker.
Yes, this is quite unusual to be to anemia to be absent, but actually the patient we did several on physical examination. There is no anemia, and আমরা repeatedly hemoglobin test করছি, কয়েকবার করছি, there was no anemia. Clinically
Mild anemia থাকবে না এটা স্যার।
ঠিক আছে, এখানে অ্যানিমিয়া থাকাটাই স্বাভাবিক। বাট আমরা কিন্তু এটা সেভার সার্কুলেশন করেছি এবং তার ক্লিনিকি প্যাথোলজিক্যাল এক্সামিনেশনও করা হয়েছে। দেখেন প্রত্যেকবারই 12 এর উপরে আসে না এগুলো। যার ফলে আমরা দুটো চার্জ দিতে পারিনি অ্যানিমিয়া।
Past history, the acute episode, only 10 days. The severe, what is the reason behind that severely was there is no past history. The feeding history is normal. So previous feeding list management night, so chronic illness measure, only acute, only 10 days history. So how could it cause it severely started and lost it? There is definitely a cause, sir.
থাকতে পারে, বাট আমরা কিছু ফাইন্ড আউট করতে পারি।
tuberculosis. No, there was no tuberculosis history. Now we are going to proceed towards our investigations. We did some investigations on the admission date, and it showed hemoglobin was 12.1, ESR 14 millimeter, WBC 9000, and neutrophil count 62%. Platelet was 3 lakh. On urine routine examination, epithelial cell and pus cell was within normal limit. Serum creatinine was 0.6 milligram per deciliter. Blood group was A positive. And plain X-ray chest, normal findings. From our ultrasonography report, we can see that there is suggestive of type 1 choledocal cyst with choledolithiasis. And from liver function test, serum alkaline phosphatase is very high, 976 unit per liter. Serum AST shows 137 unit per liter, and SGPT 269. These are also high, but not like alkaline phosphatase. And this is our ultrasonography report. And serum bilirubin level was 0.5 milligram per deciliter. Direct 0.2 milligram per deciliter and indirect 0.3 milligram per deciliter. Prothom mean time was patient was 15 seconds, and INR was 1.31, almost within normal limit. And serum amylase showed 482 unit per liter, but serum amylase is 1478 unit per liter. So our clinical diagnosis was the patient was suffering from type 1 choledocal cyst with choledolithiasis with acute pancreatitis. Patient, the next plan was to do Rho and Y hepaticojejunostomy after we manage acute pancreatitis as well as the patient's correction of patient's malnourishment. We have we have discussed with our pediatrics department and anesthesia department regarding her management and plan. And after few days, we had a plan to do the operation. After 7 days, we repeat the Pratham mean time, which showed when was we planned the operation the previous day. We did the Pratham mean time, which showed the INR was 1.63. That's why we could not proceed the operation that day. As the patient was in with nothing per oral, so we also for a long time. So we also did serum electrolytes, which was also within normal limit. Then again, we treated the patient conservatively with conachion, vitamin K, and then we again planned for the operation after 7 days. And before the operation, we also did the Pratham mean time, which showed the INR is within normal limit, and then we proceed for the operation. Preoperatively, we manage the patient conservatively. That's what we are showing here, and prepared 280 ml of fresh human blood for the patient for intraoperative transfusion. So we did the operation on 15th July, and indication was type 1 choledocal cyst with choledolithiasis. Name of the operation was total excision of the cyst with Rowan Y hepaticojejunostomy under general anesthesia. We gave Coker's incision, and the gallbladder, the findings were the gallbladder was edematous with type 1 choledocal cyst with choledolithiasis. And we sent the resected gallbladder and choledocal cyst for histopathology report. Here is a photo I have given here for your better understanding for the junior doctors here to identify the structures, so that I can talk about it, so that you can realize what I am going to talk about this later on. And this is called the Rowan Y hepaticojejunostomy. This is the cyst, you can all see. This was our type 1 choledocal cyst. This was our type 1 choledocal cyst with edematous gallbladder, and this is after the operation. We have resected the gallbladder and the cyst, and then we did the anastomosis with the jejunum. This is the hepatic duct, so this is called hepaticojejunostomy. And again we did another anastomosis here with the distal part of the jejunum. Here we made a resection, incision first to make two end, the proximal end here making the anastomosis with the hepatic duct, and the distal end making the anastomosis with the another 20 centimeter away from the proximal incision, primary incision. Now I am going to show some intraoperative photos. Here we are making the incision with the Coker's incision, and this is our gallbladder. This is our gallbladder, and this is the cyst. This is the opening of the cyst, and we are trying to excise the gallbladder with the cyst. We identified a point 20 centimeter away from the duodenojejunal junction. This is the point, and we are going to make an incision here to make two ends for the anastomosis. There are two ends you can see here, the proximal and the distal end, and here we are going to make the anastomosis. This is the first anastomosis, hepaticojejunostomy, and this is the second anastomosis, you can see here, jejunostomy, with the distal part of the jejunum, with the first distal part, and the later part is 20 centimeter, further 20 centimeter away from the primary incision. So our confirmatory diagnosis was patient was suffering from type 1 choledocal cyst with choledolithiasis. Postoperatively, we managed her accordingly. Her postoperative period was uneventful. Patient was discharged on 8th postoperative day with advice to follow up after 7 days. Thank you all.